Acute GI Bleed in a Patient with Metabolic Syndrome by Julia Yuan and Jessica Chen, MD, at the UC San Diego School of Medicine. Non-alcoholic steatohepatitis, also known as NASH, is a subset of non-alcoholic fatty liver disease, or NAFLD, and is marked by progressive hepatic inflammation with potential development of cirrhosis. NASH is typically asymptomatic but can present as fatigue and abdominal pain, accompanied by elevated AST and ALT, and is more likely to occur in patients with metabolic syndrome. Cirrhosis is often asymptomatic, but clinical exam may reveal jaundice, spider angiomas, gynecomastia, or asterixis. NAFLD-related cirrhosis is an established but underappreciated risk factor for hepatocellular carcinoma, or HCC, and NAFLD-related HCC incidence is rising in the U.S. population. Our learning objectives are to recognize clinical symptomatic progression from NASH to HCC, improve screening, surveillance, and intervention protocols for high-risk NASH patients, and apply the new 2020 guidelines by the American Gastroenterology Association for NAFLD and NASH patients in daily primary care practice. Our patient is a 68-year-old male with a past medical history of hypertension, hyperlipidemia, obesity, fatty liver, and type 2 diabetes mellitus. He presented with 1 month of fatigue, shortness of breath, nausea, decreased appetite, hematochezia, and weight loss. Physical exam showed pallor, lower extremity edema, and extensive spider angiomas, and labs showed a hemoglobin of 4.4 and a hematocrit of 14.8. The patient was then referred to the emergency department. At the emergency department, an upper endoscopy revealed multiple large esophageal varices, and hepatomegaly and cirrhosis were observed on ultrasound. He also received 5 units of packed red blood cells. The patient returned for multiple follow-ups. His labs showed improved hematocrit and hemoglobin, but he demonstrated continued weight loss and fatigue disproportionate to recovery. Ultimately, a CT revealed metastatic stage 4B HCC. This is our patient timeline, from initial presentation on day 1 to diagnosis on day 57. In addition to routine labs and physical exam, updated 2020 guidelines by the AGA recommend that all NAFLD patients receive non-invasive cirrhosis screening through at least 2 of the following every 3 years: point-of-care tests, specialized blood tests, or imaging. For NAFLD patients with detected cirrhosis or advanced fibrosis, the AGA recommends HCC surveillance through regular ultrasound every 6 months. The FIB-4 score is a point-of-care test that uses patient age, platelet count, AST, and ALT to calculate the risk of advanced fibrosis and cirrhosis. A score under 1.3 is low risk for advanced fibrosis with a negative predictive value of over 90%. Specialized blood tests include the Enhanced Liver Fibrosis, or ELF panel, which utilizes hyaluronic acid, procollagen 3 amino-terminal peptide, and tissue inhibitor of metalloproteinase 1. A score of over 10.5 is likely to indicate advanced fibrosis or cirrhosis, with a sensitivity of 79% and a specificity of 91%. Imaging options include FibroScan transient elastography, which uses both ultrasound and low-frequency elastic waves to quantify liver fibrosis. It has an 85% sensitivity and 82% specificity for diagnosing advanced fibrosis. It has a 92% sensitivity and specificity for diagnosing cirrhosis. Biopsy is the gold standard for NASH diagnosis, but due to procedure invasiveness, cost, and low HCC risk for non-cirrhotic NAFLD-NASH patients, biopsy is infrequently pursued in primary care. This NAFLD patient was asymptomatic until a significant GI bleed, with a hemoglobin of 4.4, hematocrit of 14.8, and cirrhosis weeks prior to eventual stage 4B HCC diagnosis. He is a candidate for the new AGA guidelines on NAFLD-related HCC surveillance. Early HCC detection is critical in treatment. An increased emphasis on NAFLD-NASH screening and surveillance may have been instrumental in his prognosis. Additionally, streamlining risk prediction scoring tools in the electronic medical record may increase monitoring for NAFLD and NASH patients. Our take-home points are to recognize the importance of increased HCC surveillance in high-risk NAFLD and NASH patients with metabolic syndrome, and recognize updated protocols for cirrhosis and HCC screening and surveillance in NAFLD and NASH patients using the new 2020 AGA guidelines. These are my references, and thank you for listening.